Lemaire take over.
Great, thank you. And that's
Yeah, that's the pointer.
well, thanks for the invitation to talk about genetics of complement-mediated TMA. Here we go. So I should point out, it's always amazing for me to hear Richard talk, and you have it's a huge luxury. He's probably the best person to explain the complement system, and I always learn new things. Even though I've seen your talk probably, I don't know, 5, 6 times. It's absolutely amazing. So we'll talk about genetics, and Richard laid the ground perfectly for me. And we'll go a little bit sort of broader and more general, so that it'll give you a picture of how to use genetics in your clinic. So here's some disclosures, nothing to do with this particular talk, other rare diseases. And I'm assuming here that you guys have a decent understanding of basic genetics. So I'm not going to cover very basic stuff like DNA, protein, mRNA, and stuff like that. And that you're also familiar with major forms of kidney TMAs. And Richard did a great job also to set things up. And we'll talk about why should we order genetic testing, which tests should we order, and also how to assess the clinical relevance of genetic variants. So why ordering genetic testing? So there's a lot of pros, and there's some cons as well that you need to be aware of. So you probably have heard of the shortened diagnostic odyssey, and when genetic testing was not as widely available, patients used to be, getting investigations, biopsies, and this and that without getting a formal diagnosis. And getting genetic testing early can definitely have a huge impact. It can confirm diagnosis, of course, although as you've heard from Richard and you'll hear from me, often you wish it was a clear picture, but often it's shades of gray, and you just need to assess many different things when assessing the pathogenicity. You can also prognosticate for your patient in terms of how they will do over time, how other family members may do, how post-transplant course could go. It can modulate therapeutic choices as well, and we'll talk about that. Very importantly, it can influence family planning. But of course, you need to be sure, about the consequence of the variant when you want to have an impact on family planning. In terms of cons, the future insurability. So this is really important to discuss with your patients. In terms of life insurance and things like that, it can have a significant impact. Incidental findings. So if you order broader tests, like an exome or a genome, you may have to deal with some variants that you did not intend to look for. So we'll talk about that, and it can lead to some stress for families. Depending where you practice, the cost may be, in my case, it's paid by the government, but in some instances, it's private insurance or even out of pocket from your patients. And it might not be, it can be quite expensive if you pay for it. And then a concept that also relates to the insurability is the concept of genetic discrimination. And I think we don't talk about it enough, so we'll cover that as well. So shortening the diagnostic odyssey and confirming the diagnosis. Basically, Richard has gone through that masterfully. There's a variety of lab tests available. You need to consider everything, and sometimes it's very tricky. The fluid phase can look normal, but there's clear evidence of a tissue-based disease. And so just ordering a C3 level and seeing it normal or even low is not particularly useful, even though we all do it. The clinical presentation can be atypical. So you could have a diarrhea positive, to use the old terminology, patient who ends up having atypical HUS or complement-mediated TMA, to use the most recent terminology. It also alleviates patient and familial anxiety when there's, if they get a broader clinical diagnosis and now they know which form they have, it then allows them to dig a little deeper and also know what to expect a little bit more. So better prognostication and treatment planning. So again, you can estimate post-transplant disease recurrence risk. For example, if you have a complement factor that is produced by the liver and is deficient, is a completely different picture than if you're missing a negative regulatory protein that is tissue-bound, like MCP, for example, compared to complement factor H in terms of the risk. It's not zero, but it's dramatically different. You can predict the range of possible clinical outcomes. And then there's also a movement to stop anti-complement therapies, which started in Europe, in part because of pressure from governments in terms of the expenses with these very effective but expensive therapies. And there's been a fair bit of work in recent years emerging from France and the Netherlands to identify patients for whom it may be safe to stop complement therapy. So it can be definitely helpful in those regards. Another important part is if you end up diagnosing DGK nephropathy, which is the disease that I was fortunate to discover. It's the current evidence is relatively clear that anti-complement therapy is non-efficient. It doesn't really help, so you can stop it. And it also allows you to be relatively confident that the post-transplant disease risk is extremely low. If I can tell you, it's pretty much zero. And then, yeah, so you can modulate the anti-complement duration therapy based on the high-risk genotype. That relates to the stopping sort of data that's been gathering that we've been gathered from Europe. So you can so some genotypes, in particular complement factor H, you will really not stop the therapy that much. But other variants, or even patients that do not have variants in any of the complement genes that are currently part of the gene panels, will be great candidates for this. Of course, you need to monitor them very closely. So family planning is if you have a clear positive finding, cascade testing of family relative can be helpful. And also, it can be helpful for the family to determine the probability of having another affected child. And in some instances, you can rely on pre-implementation genetic diagnosis in IVF to make sure that the variant is not present. You can also test the fetus if there's already an established pregnancy. But of course, you need a family that is willing to. Family planning. If you want to do it, it's one thing, but you need to be willing to undergo some special procedures. And if the family is not keen to proceed with that, then you cannot really offer it. Potential downsides. So I already mentioned that the cost, increased family tensions. So I've seen that in my clinic where one parent will accuse another parent of being the cause of all their troubles, and then you have to explain that genetic it's not something that you're responsible for. It just is. But it can be pretty intense. Future instability we talked about, the stress, and the unexpected findings is really important. For example, you might be testing a young child for variants that relate to a picture that appears to be consistent with complement-mediated TMA, but you end up finding a pathogenic variant that increases dramatically the risk of breast cancer, like BRCA1, for example, and then it has a huge impact for all the women in the family. And then you have to decide on how to proceed with that, and we'll talk about this in a minute. So genetic discrimination is a topic that is often not covered, and I usually try to discuss that a little bit, because it's basically any entity that is using genetic results or family history against an individual that is currently asymptomatic. And for example, in Canada, a lot of people are refused outright life or disability insurance because of genetic risk factors. And there's been, so you just need to know how things are happening in your own country. So there's been a variety of declarations and rules and laws across the world over the years, and Canada was one of the last one. But you need to know how things work for your own country. For example, in Canada, now we have the Genetic Non-Discrimination Act, which prohibits discrimination based on genetic results, but not based on family history, which is a little bit ridiculous because it's kind of one and the same. But the GINA in the US is much broader, and same thing in Europe. But has huge impact when you're discussing with a family to do genetic testing. And often it's clinicians are not really aware of these subtleties. They know about the secondary findings, but they're not aware about the potential for genetic discrimination. So which genetic test to order? So my slides are, I apologize, they're a bit messed up. It's because I don't use PowerPoint, but it's fine, it doesn't matter. The old way of doing things was to do a lot of investigations, and this is sort of the diagnostic odyssey, and at some point genetic testing might be done for your patient. But thankfully, the new approach is to do genetic testing way earlier, sometimes even during the first admission. Genetic testing is done, and the turnaround time for getting results is dramatically different. It routinely used to be 6 to 12 months in my genetic clinic to get results. And now, especially if you make a special request for a patient that's particularly sick, you can get the results very quickly. And I think in some centers, it can be as quickly as 24 to 48 hours. So really, that has dramatically changed things. The one thing that you will hear is sometimes some clinicians will say, well, maybe this is great because it will allow you to not do, for example, kidney biopsies in some instances. But sometimes more information, and Richard, I think, was talking about this, more information is better. And yes, it would be great if we could, use genetic testing as a broad cover for everything and not even do complement investigation, functional testing, or biopsy. But these are very difficult to tease out. The conditions are very difficult to tease out, and often more information can be helpful. But by all means, if we can avoid a tissue biopsy, it can be useful, but sometimes we do it. Of course, we never do it in the acute phase for these specific patients because of the thrombocytopenia. So there was a question about, panels versus genome versus exomes, and this is a nice picture where basically an exome is just giving you, you want to think about it as a genome is basically mostly not exomes or exons. It's probably less than 1% is coding regions. So the exome will only give you the coding regions of the genome. It's a bit like this apple here. If you get the whole genome, you get the whole apple. And if you just get exomes, you just get a sliver of the apple. But this is the area that we understand very well because there's been a lot of selective pressure. The amino acids are well conserved, and we understand relatively well, how to interpret variants that are in the coding regions. What happens in the introns is a completely different ballgame. It's probably very important, and it looks like most of the variants that we find are coding, but I think it's probably the phenomenon where we're looking for our keys where the light is, right? So there's still probably 30 to 40% of patients with complement-mediated TMA for whom we don't find pathogenic variants. And maybe there are none, but it's possible that they are just hiding in plain sight where we're not looking. And potentially using genome sequencing more widely would be helpful. But I think our understanding of or ability to interpret these non-coding regions remain quite rudimentary. So at this point, it can be tricky. The only thing I would say is when you order genetic testing, make sure that the genes that you're ordering don't have intronic splice site that are well described. For example, I can tell you there's one in DGK, the gene DGKE that is in the middle of an intron that will not be picked up by an exome, but the good genetic testing companies will add a targeted sort of region to capture that very specific intronic variant as part of the test. So you will know if that variant is present. So but not all companies do it, I can tell you, even though I've been telling them, I guess they need to modify their capturing system, and they don't bother doing it. But it would not be complete testing if you don't have it, because these are actually recurrent variants in this case. This is just to give you a representation of what an exome does and how well it enriches for the coding variants. So the light gray here are exons. The dark gray are the sort of the areas around the exons where the splicing occurs, where mutations are also very well understood. And you can see the y-axis here is the amount of data you get. And the white space is basically the introns. So you can see you get beautiful enrichment of data across the exons. But one thing I want you to also realize is the quality of the data can vary by exons. So if you get a negative results and you're convinced that it should, let's say that it looks like your experience, like a patient with complement factor H variant, you may want to inquire with the company if the coverage, which is this blue signal there, the coverage depth, whether it was adequate across the gene panel, or because sometimes there are dropped exons just for quality control. And they usually will say that on the report. They will say, well, we cannot comment on exon 19 because there was very little data. Okay, so, and here's a slide that I think is quite useful to show you how to evaluate for different types of variants. So here we have, and I apologize, it's a bit messed up, but on the y-axis is the size of the changes that you're looking for, okay? So at the one or a few bases level, it's SNP genotyping, so that's very simple. If you go a little bit broader, oh, yeah. So it's SNP genotyping here for very, very small variants. Sanger sequencing, which used to be, the common way of doing things, very manual intensive, or next generation sequencing is very good for slightly larger or even smaller. You can pick them up using this approach. But if you go larger, then that's where you want to use other approaches. So you probably have heard of fluorescent in situ hybridization, or FISH. So this is to look for changes in your relatively large changes at the level of the chromosomes. We've heard about MLPA, and that was one of the questions as well. So you can find rearrangements that can be relatively small to relatively large. And one important thing to remember is the exome data that you're getting is you can make a call on some of these copy number variations, but it's relatively tricky and not very reliable. Genome data can be quite a bit more accurate, but often if it's unclear and you haven't done a proper copy number variation assessment and you've got a patient with an exome, let's say, or a complement panel that is negative, it might be worthwhile to proceed with an MLPA. And then there's also array CGH and karyotyping that are other types of methods to look for large amount of variation. I will not go into detail with how MLPA works. Suffice it to say that it's excellent to pick up these copy number variation, and it's pretty much standard to look for these very complex complement factor H region or the RCA rearrangements that Richard so beautifully explained to you earlier. So how to choose the best test? So you can do a single gene test if you're really, really feeling confident, but I think very few people would do this. You can do a panel, which is probably, and I think that was one of the questions and everybody answered that, that is specific for the phenotype or the condition. You can do a specialty panel where basically it's all the gene known to cause HUS. You can do genome-wide or exome-wide. But what you need to do is shop around. And maybe your genetic testing or genome diagnostic unit at your institution will help you with that in terms of cost and turnaround time. But it will be your responsibility to look for which genes are covered. For example, some companies are way quicker to update their panels if there's a new gene that has been reliably and robustly demonstrated to be disease associated. And also, in many instances, many companies will include carrier testing as part of the deal, so which can be a quite valuable feature. And finally, if you order broader testing, and like an exome or a genome, and you want, let's say you're offered to collaborate with a researcher to identify, the disease-causing mutation for your patient, you along with your patient, can make a request to the company to download the entire exome or genome data for further analysis. So this is something that you would be able to do if you wish to do so. Maybe not yourself, but if you collaborate with somebody who has bioinformatics skills and can do it, it can be something that can be done. And here I just showing you, I just did a broad, hold on a sec, it's not nephroliphesis. I don't know why it's nephroliphesis. It's, I have multiple talks, but this is for HUS. So Blueprint as a panel for HUS that has 9 genes. It looks for intronic variants. Remember, we're talking about this. The price is not so clear, and the turnaround time is 4 weeks, which is pretty good. Prevention genetics is 610 genes, so it's much broader. They don't have a narrow panel for this particular the complement-mediated TMA. The price is $2,000, and the turnaround time is 3 weeks. GeneDx has nothing about this, and there's also Natera in the U.S., or they have their Renasight panel. I'm not sure if you're familiar with it, but it has well over 380 genes. That includes pretty much all of the complement-mediated TMA genes. It does look for intronic variants. It can be free for some patients in the US, and the turnaround time is 4 weeks. So now, assessing the clinical relevance of genetic variants. So that's the tricky part. And so what we'll do is we'll talk a little bit about the ACMG variant classification. So we have a basic understanding of how this works. We'll talk about how to handle variants of unknown significance, addressing negative tests, and also talk about incomplete penetrance. So this is a nice image to show the range of possible interpretation that ACMG guidelines will give you. It goes from benign, likely benign, uncertain, or VUS, likely pathogenic, and pathogenic. Okay, and it's relatively straightforward. If your report states that this is a pathogenic or a benign variant, chances are this is correct, and it will probably not change if you're getting the results right now. Okay, and we'll talk about an example where getting old results and realize them is absolutely critical. Typically, the benign and likely pathogenic and pathogenic are kind of grouped together as being, you know, of relatively robust significance. Unfortunately, the bulk of what you're going to get is in the yellow, so the uncertain phase. Okay, so meaning that you're happy, you know, as a clinician in terms of reporting the results to your patient if you're in the green or the red or the quasi-red or the quasi-green, but mostly you're going to be in the yellow. So pathogenic variants, there's very strict criteria as per ACMG guidelines. And typically it would have to follow the expected pattern that we know for the particular disease. So is it dominant, recessive, X-linked? Typically the minimal frequency in large control databases like Nomad, and we will show you some examples in a minute, has to be low. I mean, Richard did mention that it's, you know, the allele frequency can be tricky to interpret, but if it is causing a rare disease that is relatively severe, even if there's incomplete penetrance, a variable expressivity, it would be unusual to have a variant with a minor frequency of 40%, which means very common, to cause a very severe rare disease. So sometimes you can make a pretty easy call based on allele frequency alone. So if it's been reported in other patients with the same phenotype, it can be useful. Looking at familial co-segregation can be useful, usually in genetics, but in complement-mediated TMA, it can be tricky because of this incomplete penetrance and variable expressivity. So it's useful to know. I would say in particular if it's a de novo variant as well. So if none of the parents of the variant, it can suggest to you that this is likely a pathogenic variant. It has also huge consequences in terms of family planning because the likelihood of having a recurrent de novo variant within a family is not zero, but it's extremely, extremely low. And then one thing that we look at, so a lot of us here are part of the ACMG ClinGen panel for the complement-mediated TMA. We also look at some of the work that Richard has shown us, really elegant work where deep functional assessment is being done for specific variants. Unfortunately, for the bulk of variants that we are seeing in the clinic, these data are not available. So you cannot really rely on that. But if it's available, that's great. Benign, so very unlikely to cause disease. You can be quite confident, if you're getting a benign variant, that it's probably not doing, it's not causal. It doesn't mean that it may not be a risk variant. And Richard really beautifully presented some data about common variants that can influence the complement system. But in terms of being the disease-causing variant, you're probably pretty confident that it's probably not the case. Usually, the minor allele frequency is too high in the general population, again, to cause a rare disease. And then you may have silent variants as well. So in this case, a leucine to leucine at position 9. Remember, the amino acid system is redundant, so you get multiple codons that will give you the same amino acid. The only thing to remember is sometimes they're not so benign. So at the amino acid level, it looks benign, but it can actually sometimes impact splicing. So just something to remember. But the current reports that you're going to get will typically include that as part of the report. But there are softwares that you can use to test for it if it hasn't been done. So variants of unknown significance. So it doesn't meet criteria for pathogenicity. It's not benign either. It's the most likely type of variant that will change status over time. So it can be upgraded to pathogenic or downgraded to benign, depending on the evidences that will be gathered. Co-segregation analysis can help, usually, but again, it can be tricky for complement-mediated TMA. And reporting variants increases the likelihood of a conclusion. So this is really important for everybody in the audience. And that's something that we experience as part of ClinGen, is you may think, oh, there's already hundreds of complement factor H variants or whichever other genes you find with your patient. So why would I bother reporting this? It's really important because it allows other clinicians that may have the same variant to draw more robust conclusions, because this variant may actually have never been reported, and it can be very helpful. And it can be very helpful to determine really the wealth of variants that may be disease-causing. And if you don't feel like you have the time to write a case report or a case series, I would strongly encourage you to look at the website ClinVar and just input your variants there. You might need the help of your genetic team at your local institution to do so. They don't make it as easy as they should. If there's no variants identified, then you're back to the drawing board. So you have to ask yourself, is there a high probability of a genetic etiology? For example, if you have multiple affected family members. If yes, probably more testing is indicated. Or if you have a patient that has particularly severe disease or some unusual extrarenal findings, these would be probably instances where you might want to go broader. And typically, if you keep testing, you want to go broader. If you've done a genome, you don't want to do an exome or a panel, because the data is really robust and it will be completely redundant. So it's probably good to start narrow and go broader as needed. And consider microarray or MLPA if you consider this copy number variation. So one important phenomenon that makes everything really challenging is the concept of penetrance and expressivity. And this little drawing on the right-hand side shows you what these terms mean. So incomplete penetrance means that all of these people represented by squares have the variant, but only the blue ones will have the disease. And in this case, you could say it's 60% penetrant. Variable expressivity, you can see there's no white squares. So everybody has the disease, but the disease expression is quite variable. And one of the great examples for this is cystic fibrosis, where family members with this exact same variant will have extremely variable disease expression. And then if you've got both incomplete penetrance and variable expressivity, then the array of findings that you can identify even within a family is incredibly complex and makes it really difficult to assess what is going on in a sort of strict Mendelian fashion. And this is precisely, unfortunately, what's going on with much of the complement genetics that you're going to be faced with. There's very few instances where clear Mendelian patterns are observed, except perhaps homozygous complement factor H mutations and homozygous DGKE pathogenic mutations. But even then, there are occasional reports where a patient that looks like they should have the disease, they do not. For example, there's a patient with a homozygous DGKE variant that should have the disease and does not. I personally thought it was maybe one of the true Mendelian conditions, but if you look deep enough, you're often going to find that there's almost no black and white in genetics these days. So parental and sibling testing can be very useful to determine carrier status, to clarify phase. So this is really important when you have a patient where you find two heterozygous variants, because if they're in cis, meaning they're actually on the same allele, and you have two loss of function variants, that will be, it's like you're cutting my leg at the foot and at the knee, but the same leg. I still can't walk, but it doesn't really matter. But if you cut both of my legs, then I can't run. So this is really important to figure out. And one of the best way to do this is through testing of the mother and the father to clarify this. The other thing that to remember is sometimes you will have a variant that looks like it's benign and a variant that looks like it's pathogenic, but they're in trans, and the disease that you're going to get is a little bit worse because you have just a copy of the gene that is working less than it should, and it cannot be compensated by the allele in trans that is completely dysfunctional. Another thing that often we don't talk about is when you start doing family testing, you need to be aware of non-paternity events. And so basically, and this is really important, for example, if you want to prove that a variant is de novo for your patient, which has significant clinical relevance, you need to be sure that dad is dad. And it's surprisingly common that where it's not the case. It can be upwards of more than 10% in some communities. And then, handling that, if you're faced with this situation, there's a fair bit of literature on this, on how to handle this. But it's something that you need to be aware of. If you're going to start doing family testing, you need to be ready to deal with this. And it might be worthwhile to do it with the help of your genetic team, who are fully trained to handle these situations. One thing that's really important is to revisit your patient's result, okay? And when I mean that, for example, if you have an exome done in 2014, the vintage is critical. Even if it was positive, it's not a closed story. I would say if it's done in the past 3 or 4 years, you can be more confident. If it was negative and done more than 5 or 10 years ago, absolutely consider retesting, because the technology has advanced dramatically. New genes have been included, including DGKE that may not have been tested. So checking for novel disease causing genes is also important. These are free online resources that I would strongly encourage you to familiarize yourself with. So NOMAD, or the Genome Aggregation Database, hundreds and thousands of exomes and genomes, and you can look for the minor frequency for your specific variant. Really easy to use, very informative, because sometimes the reports don't make a lot of sense. And I'll show you some example. HGMD, the Human Gene Mutation Database, these are patient mutations that have been relatively well vetted, so you can be fairly confident that they're pathogenic. So if your patient's variant is there, and it should be in the report, it can be a good indication that this is a good pathogenic variant. ClinVar I mentioned already. It's a publicly available database or archive for variants. So you could even post your own variants there. OMIM is where you learn about genes and disease association. It's good to familiarize yourself with genes that you don't know about. This is just to give you an example. So this is a completely different disease, but I've been monitoring this for one of my lecture on genetics for the fellows at SICKITS. This is for congenital nephrotic syndrome. But I think it drives the point, and this is in every single gene, okay? So this is from HGMD, this database I told you about, and I've been monitoring it since 2012. And what I want you to appreciate is these are all different types of variants, okay? And the number is going up dramatically, okay? Splicing, missense, nonsense, you name it. I guess regulatory is tricky, so not surprising that it stays pretty low because we understand very little. But if you look at the mutation, so if you have a report that's done in 2012 and it's labeled as pathogenic or benign or whatever, and now we have almost 3 times as much variance, you're dealing with a completely different ballgame. So this is really important for you guys to figure out. So to give you an example, so this is a patient where targeted gene sequencing was done in 2009. And I saw this patient in 2021 in the clinic. And her sister had atypical HUS at the time, or complement-mediated TMA. She was treated with tocilizumab, and had all of these variants that were picked up. And this one at position 1050 was expected to cause disease in the heterozygous state. So the patient was labeled as a complement factor H mediated disease. The sister was tested as part of the sort of co-segregation analysis and was found to be positive, never had any symptoms. And she was monitored actively in our clinic on that basis, never showed any signs of disease. And basically what I ended up doing is, so this is the human gene mutation database, and you can just plug in, you have to log in, which is free. You put your gene name, then you pop this window, and then you can go to, in this case, it was a missense, so you go here, you drop down, and you figure out if your variant is there. And often it's not there, which is fine. But if it's there, then you're golden. If it's not there, then you can go to Nomad. And here I'm just giving you, so it's 730,000 exons and 76,000 whole genome from unrelated individuals of diverse ancestries, incredibly rich data set. So here you do the same thing. You find your gene. You can go down here to the position. So for me, it was 1050. You just enter it here to string thing. It turns out the variant is right there. What I want you to do is click on that small link there, because then you open up this page with the allele frequency that is ethnic specific allele frequency. Because often the report will give you the aggregate allele frequency. But if you have an ethnic group where this variant is more common, but it accounts for very little amount of the data in Nomad, the overall allele frequency can be extremely low and look like it would be consistent with the pathogenic variant, but it might be 5% in Latinos, which clearly cannot be pathogenic for severe rare disease. Okay, and so it's too small on the screen for me. But so this is exactly what I did here, and you also get as part of this what Richard was talking about in terms of the in silico predictors. So there's F4 here. There's a few other IOP, polyphen, which is super old, and they all say that it's Greek, so it should be benign. But here the allele frequency was too high. Okay, like here it's 2%, and basically it's high at everybody. But at the time when this report was done in 2009, the tradition was to sequence 100 people and see if the variant was there. If it wasn't there, it was rare. So now we have this amount of data, but nobody had bothered to revisit the results, okay, until 2021. So then what it ends up happening is I undiagnosed the sister that was affected, because now she doesn't have complement factor VIII disease. And I also unmedicalized her sister in a way until we find what her sister has. So this is something really important to do, especially for older vintage tests, okay? And here, just before finishing, I just want you to know, if you start digging in the literature, and Richard and everybody else that does complement stuff probably knows this, the terminology change over time. So if you go back to a paper in the 1960s or 1970s, you need to know how the different genes that we currently know were called, because otherwise it's very confusing. So I would encourage you to look at if you're digging in the old literature, these papers are your map to figure out who talks about what, because it can be very confusing. But it was very helpful for me. And as you can see, so 1968, 1981, 2014. So it's been revisited over time, and they usually have a table that's showing you how things are named and for what. So just a little tidbit about the messiest, I call it the messy history of complement gene names. So before finishing, so are we doing for time? Okay. So just a few survival tips especially for the clinicians in the room. If the phenotype is clear, narrower testing is preferable to decrease the risk of incidental findings. If testing was done more than 5 years before, reassess the results. If it was negative, please consider to redo the test with the current vintage analyses. If it was positive, if positive with a VUS, you need to realize your variant to see if it was upgraded or downgraded to pathogenic or benign. If you don't feel comfortable doing it, you can actually ask the genetic testing company to do that for you, and usually they will do it. If broad test is negative, an exome, do not order a narrower test. So here, if you have a negative exome, the next step would probably be a genome if you really, really feel that it's genetic. But you need to be ready for the challenges of analyzing a genome. Be ready to discuss the implication of local laws or lack thereof regarding genetic discrimination. And it's more your prerogative to figure that out depending on where you are. Discuss with the family the pros and cons of genetic testing early. Consider referral for gene discovery if negative testing, but a high probability of genetic etiology. For example, if your patient is the product of a consanguineous union and you do not find anything, chances are this is still a recessive disease. And you might have stumbled upon maybe a patient that has a novel form of the disease. And if you're not equipped to do this locally, there are many people, including myself, that would be more than willing to have a look on your behalf or do more broader sequencing. I would strongly ask you to consider writing case reports on patients with VUSs that are potentially pathogenic. And this can be if you're busy with your clinical duties, it can be a great thing to do with a fellow. And this is personally what I did when I was considering to do genetics as a fellow. I actually took it upon myself to write a case report on a variant in causing nephrogenic diabetes insipidus, and it really forced me to understand how to report genetic variants, and it put me in a path to be way more actively involved in genetics. And it's pretty straightforward. And when in doubt, consult an atypical HUS or complement-mediated genetic expert or genetic counselor. And there's many of us in the room that are more than willing to answer your questions, pop an email. In pediatric nephrology, we also have PetNeph. If you're not a member of that, then you're a pediatric nephrologist, come and see me. But we have this board where you can post questions and people will chime in. So I guess that's it. So I'll be happy to take questions if there's any. Otherwise, I think we have cases, right?
Yeah, we do. Yeah. So thank you. That was very, very comprehensive. There are two questions from the audience, Matthew, that I'd quickly want to bring up, and then we'll take a break from 1:45 to 2. You can sit there if you want. So one of the questions is, in those cases that are negative for any panel or exome and MLPA, would you consider any strategy for RNA sequencing?
It's tricky.
Not what can you pass the mic?
Question. Should I just come back?
No, we'll use the mic.
So this is a great question, but the issue is you need to have the right tissue because often like One area that's been super successful for this is, for example, muscular dystrophy conditions where you can have easily access to tissue that's highly relevant to the disease. And then what is being uncovered are alternatively spliced versions or major isoforms that are missing that are hard to pick up on sequencing alone. And typically what happens is you find the aberrant isoforms on the RNA-seq, and then you backtrack and figure out how it happened genomically, and then you can find the disease-causing variant this way. But for complement-mediated TMA, it's a little trickier because you need to know what tissue are you going to be looking at the kidney, because if you take blood, is it relevant? It could be done, but it's a little tricky, and it's definitely not available clinically. So if you want, because one thing to remember is if you do something in the research sphere, this is not something that you're supposed to be using clinically. It has to be done, for example, in the US through a CLIA certified lab, where you know the result is true or, robust. And if it's a research test, usually clinicians are not encouraged to use it to modulate clinical care, even though, it can be useful. So in this case, RNA-seq can be useful to understand the basic biological principles or the pathophysiology, but it's unclear at this point if it would be useful to modulate your management. But excellent question.
And the second question that also comes from Brazil is, given the unfortunately high frequency of VUS detection in patients with underrepresented populations, something that you were alluding to earlier, and the limited accessibility to functional assays in some countries, what is your opinion on AI-based models such as deep learning methods, or there's a Gibbs-free energy changes and/or AlphaFold? Familiar with those?
So excellent question. So the issue so I talked about the databases of control variants. Everybody needs to be aware that there's significant bias in what the information you can glean. For patients of European descent or African American and other ethnicities, it's starting to get a little bit better. But if you have a patient, for example, I don't know, from Papua New Guinea, chances are we do not have, everything's going to look rare. And then it makes it really challenging to draw conclusions from that. But so there was your question about, so what about VUS? And then the second part, what was it?
Whether you could use an AI-based models for functional.
Okay, so yes, you can. The problem, and Richard alluded to this, the prediction from these fancy tools is just as good as when you look at the functional assay, it's really not that good. And the other thing I should remind you, so if you remember one of my slides, I had all the, CAD score, polyphen, phylo-P, and all this. If you dig some papers that do the cross comparison of all these tools together, the Venn diagram of this, where they agree, is actually surprisingly small. Unless it's clearly benign or clearly pathogenic, in which case you really probably don't need those tools. You really need them for the tricky ones. But if for those VUSs that are in the gray zone, then you need to make an educated guess. Well, do I trust CAD score more than, which is more integrated than polyphen or phylo-P or whichever? There's probably 15 tests that exist. But then if you're biasing your results based on what you think is true, so AlphaFold is great, and Gibbs energy and all of that. You can do, in silico changes of the crystal structure if it's available. But this is all somewhat helpful. But at the end of the day, I don't think it's, especially for complement-mediated TMA genes, that it's super useful. I don't know if, Richard, you want to comment on that?
Yeah, so I agree. That was a great question. Part of the, so I think there's a huge move to use AI, AlphaFold, and all the predictions, but the classification of genes as pathogenic is done by a committee. You're chairing it with David, and the annotation of variants is also done by a committee. And to reach moderate or to reach at least a moderate level for a gene requires multiple series of evidence, of which AI and AlphaFold and computer predictions is only one part. And so even if you had great predictions, you still wouldn't move a gene without other levels of evidence from limited to moderate. And if a gene is classified as limited in its association with the disease, then any variance in those genes can never be classified as pathogenic or likely pathogenic, which is why when Matthew said if you have a variant that you find in a gene that's, another variant in MCP or whatever gene, and it hasn't been reported, report it somewhere, because otherwise it can never, our knowledge base of genetic variants will never increase.
Thank you both. So we'll take a break here, and we are going to come back for a panel discussion. Everything that Richard and Matthew have talked about, we are actually going to